you go.
Thank you. Thank you very much. Very nice to be here. So I'm going to talk about employment, and actually many of the things that Dominique was saying in healthcare settings in terms of stigma and so on are echoed very much in the labour market and in workplaces. I work at the Institute for Employment Studies. It's a 50-year-old not-for-profit organisation based in the UK. It does evaluation research, both for policymakers and for employers. We have quite a big programme of work looking at health and well-being in the working age population, and we focus quite a lot on chronic and fluctuating health conditions and how they affect people's participation in the labour market and social inclusion. I'm also the chief investigator of the world's largest supported employment randomised control trial, I found out the other day. I knew it was big, I didn't realise it was the biggest, focusing on helping unemployed people with mental and physical health problems get back to work. So there'll be in excess of 11,000 people going through that trial, which went live last week. I was also part of a review that the UK government commissioned from Professor Dame Carol Black, who's a rheumatologist, a couple of years ago. The UK government gave her an answer, which was, we want people who are dependent on drugs, alcohol, and are obese to have their welfare benefits taken away if they don't agree to go into treatment. Please, can you work out how we put that into practice? Which is quite an interesting way of doing it. Luckily, Dame Carol, being a clinician, understood that it's a lot more complicated than that, and she surrounded herself with an expert group, including myself, who in the first meeting said, that's the wrong question, and we produced what I think was a good report explaining why forcing people to go into treatment is not the answer, and it's a lot more complex, but everyone here knows that. So I'm going to talk about discrimination in employment. Let's start off with a definition. I think discrimination is about giving or receiving different, usually worse, treatment, solely because that person belongs to a certain group or a social category. And obviously we're used to looking at discrimination in employment on the grounds of gender, ethnicity, disability, sexual orientation, faith. In the UK, that's what we call protected characteristics. If they're embodied in equalities legislation, it's illegal to discriminate on the basis of those characteristics, so we call them protected characteristics. And that's a theme I'll come back to in a second. So I have no conflicts of interest. I'm going to talk about the concept of inclusivity in labour markets and why it's a policy priority, not just in Europe, but in other developed economies. Look very briefly at what the evidence says about overweight, obesity and productivity. Look at stigma, discrimination and labour market participation. Looking at this idea of a protected characteristic, and there's relatively new case law in Europe at least that offers some hope for those who feel that this obesity should be regarded as a protected characteristic. And then perhaps talk about what some of the main stakeholders in this domain really ought to be doing about this. So let's have a look at the policy landscape which sets the context for this. And I'd say, first of all, this is not obesity specific. It is, in general, a whole range of issues that are affected by poor workforce health. The working age population is changing. For a start, it's getting older. In most developed Western economies, we're all having to work longer because of pension provision being so poor in many countries. People are retiring later. There's more chronic illness. That's just a sort of epidemiological fact of life. And when you combine all that, then it means that because our definition of what's working age is extending, so my daughter's just left university, and I told her with a smile on my face the other day she's going to be working till she's at least 70. That's quite a depressing thought, but I'm good at motivational speaking, as you can tell. But we're having to change the way we think about what working age means. And as we work longer and are older, we develop more chronic ill health and, as I'll mention in a second, more comorbid conditions. And of course, the other challenge is that we've got widening health inequalities, and that's particularly relevant in the case of overweight and obesity, because there is a strong social gradient in health for people living with obesity. That's reflected in all the obesity statistics. And also we know from a health inequality perspective that work is a social determinant of health. So all these things are very closely linked together. So if the health of the workforce is deteriorating, even though we're living longer, but living longer less healthily, that has all sorts of economic and social consequences. It reduces productivity, the productive capacity of the workforce. It means there's more social exclusion and poverty, greater and burden on families and carers, greater welfare spending, less tax revenue, when people are working less, increased healthcare costs, and early or premature withdrawal from the labour market. So all these things are linked together, and if you're sitting in Brussels or in a national government, these are things that are preoccupying you as policy priorities that really need to focus on. In terms of productivity, we know that in the United States, for example, nearly $12 billion of lost productivity is attributable to absence from work amongst people living with obesity. People can be less effective at work because of their condition, their absence from work, presenteeism, which is people coming to work when they're not feeling 100%, and also premature withdrawal from work or early retirement. And the way we count this is sometimes quite deceptive. Quite often all we do is count the direct costs of healthcare for people living with obesity. In general, that accounts for probably only 20% of the total costs. The indirect costs are much bigger in terms of productivity lost, losses to organisations and employers, but also impact on carers and other family members. So lost productivity owing to presenteeism makes a larger contribution overall than lost productivity due to absence from work. So this chart basically shows that there's a strong positive correlation between the degree of obesity and both work and activity impairment. So on the left-hand side, you've got a cluster. So each of the coloured bars represent different levels of severity of obesity. Absenteeism goes up as obesity gets worse, but actually presenteeism have higher bars, so probably 2 or 3 times as big an impact on impairment, sickness, absence. And it affects not just people's ability to work at all, but their performance or their contribution at work, and also their activities of daily living. Here's a chart showing some forecasts of the prevalence of long-term health conditions amongst the UK working age population in 2030. The 2 big ones are mental illness and musculoskeletal disorders, accounting for well over 50% of the total. But we have others which are making a significant contribution to that. So cancer, chronic obstructive pulmonary disorder, diabetes, particularly type 2 diabetes, coronary heart disease, stroke, asthma, and so on. I was told reliably recently that the condition that affects productivity most is allergic rhinitis. It doesn't affect, it affects lots of people, not enough to make them have time off work, but the productivity losses affected by people with hay fever are very significant and tend to be understated. I digress. What you see on this chart, though, is that when you overlay this with overweight and obesity, you begin to see the effect of comorbidity in the working age population. On average, about 1/3 of people, for example, with a mental illness will have a musculoskeletal condition. It's not always that they develop the depression or anxiety as a result of their musculoskeletal health. There's a bidirectional element to this. And of course, we're used to talking about comorbidity. There are lots of people at this Congress talking about comorbidity from a clinical perspective. Probably not many people will be talking about the impact of comorbidity in workplace settings and the effect that has on your ability to make adjustments for people at work, to manage job retention, to manage vocational rehabilitation. It makes life more complicated, particularly for non-clinicians, i.e. your boss. And that's something that I think we ignore at our peril. We also know that musculoskeletal conditions like osteoarthritis, for example, obesity is a bigger risk factor for osteoarthritis than it is for type 2 diabetes. but no one ever says that, because statistically it's true, but all our attention is on diabetes for obvious reasons. There is impact on sleep quality, for example. The mental health obesity relationship is complex. Clearly there is an elevated risk of developing depression. We also know that people who are on antipsychotic drugs for schizophrenia and bipolar disorder are also at higher risk of developing obesity. So it's very complex, and of course it's complex in a clinical setting. How does it feel to be an employer dealing with this increasing complexity? We know that in the UK, by 2035, 75% of UK adults will be overweight or obese. And so it's employers, as well as policymakers, who will have to be thinking about this much more. In the UK labour market, the fastest growing group of people in the workforce are people over 65. And you can see that as they age, their risk of developing multiple disorders and multimorbidities grows very significantly. So this is going to be a fact of life. We're not going to be able to ignore this. Employers aren't just going to be able to say, we'll only recruit healthy weight people of prime age. That's just not an option anymore, because the diversity of the workforce is going to force them to think a bit more creatively about how they recruit people from a range of different backgrounds. So let's have a look at this issue of stigma and discrimination. And it was interesting listening to Dominique talk about stigma in healthcare, because there's just so many echoes of what she was saying in what I'm going to talk about. So just think about your job. Being in employment, or trying to get into employment if you don't have a job, relies on a lot of other people forming judgments about you, assessing you, and making decisions about you. We all like to believe that meritocracy is the dominant decision-making framework that affects employment, whether you get a job or whether you're in work and you're having opportunities to do different types of work or develop your career. But as we know only too well, these decisions are informed more by subjectivity, stereotypical beliefs, bias, and judgment that are rarely consistent or value-free. And so in any part of the whole process of employment, whether you're unemployed and trying to get a job, or you are in work where you want to progress or develop your career or improve the quality of the work you're doing, you are subject to subjective decision-making based on a whole range of not very scientific perceptions. And we know that employers make judgments about people based on their views about personality, for example, or character. And again, we heard a bit about this when we heard about primary care physicians in the previous presentation. But people living with obesity, for example, are frequently in employment settings or in the labour market regarded as having less self-control, being lazy, having poor levels of competence, having low levels of emotional resilience, low levels of persistence, and as being unreliable. And of course that affects outcomes. So here's a list of outcomes. We talked earlier about children. One of the things I think is important is that there's a life course aspect to this. So people who are children who are obese or overweight clearly will have issues about their education, but it also affects their chances of getting work once they transition from education into employment. And that's something we often miss. And I think there's probably evidence that increased pressure from social media also has an effect on this, and I'll come back to that in a second. We know that 45% of employers are less inclined to recruit obese candidates when faced with the choice of people with normal weight. Obese people are regarded by employers as having less ability to be leaders, have less career potential or potential to be promoted. They tend to have lower starting salaries. They tend to work longer hours. They tend, in general, disease discriminatory practices very markedly affect women more than men. There was this phrase that I heard called the aesthetic labour market. So there are certain sectors of employment where how you look is quite important, how you present yourself. There's a very large hotel chain in the UK which got into trouble recently because it sent round guidance for women about how to present themselves. And there's a case recently of a woman who was temping in an organisation who was sent home because she wasn't wearing high heels and a short skirt and so on. So, you know, all this sort of stuff goes on. And I think where there's a perception that women in certain roles, particularly in retail or in settings where they're supposed to be presentable, obesity doesn't fit into that stereotype at all. And we all know that's wrong. We all know that doesn't say anything about the person's competence or their personality or their ability to do the job. It's at surface level, but it has a tangible impact. And I think, again, there are examples where social media and pressure on women to live up to what's called the beauty ideal affects women living with obesity and overweight more than men. More bullying and harassment is experienced by people living with obesity. And of course, as we've heard, there are persistent beliefs amongst healthcare professionals, employers, and the wider population that overweight and obesity is volitional, therefore as a result of a choice or bad choices. And this is the thing that seems to me to be at the heart of the problem about discrimination and stigma. The beliefs, which I think, as we heard in the last presentation, can be to an extent tackled by education, that obesity is a sort of modifiable health risk. It's a lot more complex than that. And if we're having trouble getting clinicians to believe that and to embed that in their clinical practice because they're supposed to know about this stuff, what chance have we got in affecting the way that employers feel and the way they behave? Now, there is some hope if you believe that regulation is one of the ways of doing this, that advocacy and exhortation and persuasion and social marketing and so on ain't going to work with employers. How about the stick rather than the carrot? So there's this concept of the protected characteristic that I mentioned before. In Denmark, there was a case of Mr. Kaltoft, who was dismissed from his job in a nursery, I think, kindergarten. They had lower workloads. They needed someone to lose their job in order to reduce their costs, and they chose him, and he was morbidly obese. And he claimed that his dismissal was primarily down to his obesity. The choice of him rather than other people who'd been there for the same amount of time, did the same type of work, was attributable to his obesity. And it went through various levels of the legal system. The European Court of Justice cautiously ruled in his favour, but was cautious about recognising obesity as a cause of discrimination itself. So it wasn't prepared to say that obesity is always a cause of discrimination. What it did was use the Equalities Directive. For those of you who are really keen on European directives, you'll notice that it's the wrong number. Anyone notice? You get 20 euros? Yeah, I saw that one. It should be 2078. 2079 is about mobile workers in the aerospace industry, I discovered. So it's a typographical error that led me down an interesting rabbit hole. Anyway, 2078 is the Equal Treatment Directive, which basically guides all EU member states on what equality legislation, equal treatment looks like in employment and other settings. And so what the European Court basically said was that we are going to allow discrimination on the grounds of obesity where it aligns with our definition of disability. Therefore, workers' obesity must share the same characteristics provided by the Convention of Rights of People with Disabilities. That sounds very complicated, but it's quite a neat way of getting obesity included as a protected characteristic. And the reason why that's a neat trick is that it means that we can look at obesity as being a protected characteristic if it results in a long-term limitation that hinders full and effective participation in what it calls a professional sphere. So it's about looking at obesity in terms of its effect on functional impairment, the extent to which it means that because of your obesity, you're not able to perform certain activities that are important to your job. And it's now established the principle that you can't be discriminated against if your obesity causes you to have functional impairment, just as grounds for dismissal, for example. So the other good thing about it is it it foresaw that some people would argue that it's the individual's fault that they're obese, back to my volitional point earlier. And what it says is, it doesn't depend on the extent to which the person may or may not contributed to the onset of their disability. So, for example, you wouldn't ever think of discriminating someone with lung cancer because they happen to be a heavy smoker in their youth. It's the same thing. You could argue it's your fault you've got lung cancer because you're a heavy smoker. In the UK equalities legislation, which is the one I know best, automatically you have a diagnosis of cancer or multiple sclerosis and a number of other conditions, you're covered by the equalities legislation, regardless of what it is, or indeed whether you get better in the case of cancer. So the focus here is the extent of functional limitation rather than their causes. And I think that's really, really important that we focus on that. I'm not necessarily saying that we should stop trying to persuade employers to become more enlightened, but if we have a sort of, as a baseline, some regulatory support that says actually it's unfair to discriminate against people whose functional impairment is attributable to their obesity, then we've got something to work with. And of course, in this environment, we need to work with whatever we can. So, what should everyone be doing about all this? Just to finish, I think it's pretty clear that clinicians need to be thinking about work as a clinical outcome of care. I mean, I go to so many of these conferences. I listen to very earnest and worthy and very well qualified clinicians, and no one's talking about work as an outcome. It's really interesting. And of course, you know, everyone's very interested in their clinical research or their clinical practice and so on. But work matters to their patients if they're of working age. And I've certainly witnessed several examples of specialties where nobody asked about people's work until the fourth or fifth consultation. So I think that's an issue. We need to think about the system, the healthcare system regarding work as a clinical outcome, because it matters to people. And also it recognises that work, particularly good quality work, has therapeutic benefits for people. So it's not just about economics, it's about work as being a social environment, for example. Policymakers need to be thinking much more about prevention. They need to focus on multi-policy initiatives that promote job retention. It's far harder to get someone back into work if they've left work because of their health or their health condition than to stop them leaving work in the first place by providing support, providing reasonable accommodations and so on. There's my issue about the protected characteristic and the extent to which that should play a part of the fabric of this, shouldn't be the dominant thing. And also where we do have regulations, like most European countries have regulations about making reasonable adjustments and accommodations for people in terms of the physical work environment or working time and so on, or where they work. We need to start enforcing some of those regulations. And actually, the record in Europe is very poor in many countries. You know, labour inspection is terrible in many countries and badly resourced. So actually, many employers realise that they can pretty much get away with whatever they want in terms of managing people with chronic and fluctuating conditions. Employers need to focus much more on what the person can still do. So don't look at the person as a bunch of symptoms. Focus on their capacity rather than their incapacity. Now, these have to be supported by things like sickness certification from the healthcare system. In the UK, for the last 8 years, we've had a fit note system. So rather than having a sick note, your family doctor has to write you a fit note, which goes both to you and your employer. And it says, you have this condition, here's my diagnosis, this is what I'm going to do to help support you as you manage that condition, but you could still work if your employer was prepared to make the following adjustments. So rather than saying, you're off sick, have 2 weeks away and then come back and see me, they try to focus on what the person can still do, how the employer could make some adjustments to keep that person in work. Now, it hasn't worked brilliantly in all parts of the country, but it has changed the way we talk about job retention and return to work. And for the first time, we've now got family doctors thinking about, does work matter to this person? And would them staying in work, perhaps adjusted work or on light duties for a temporary period of time, be therapeutically beneficial to them? And I'd like to see more countries doing that, I think. We need to focus on developing skills of job redesign for managers, vocational rehabilitation, creative ways of making reasonable accommodations. Someone, I think with multiple sclerosis, when I was doing a piece of research, said to me the best reasonable accommodation that you can have is a great boss. I think that's probably true. And then we need to focus on individuals, remember them? We shouldn't just be doing stuff to people, we need to include and involve people living with obesity in self-management. We talk about self-management in clinical settings. We need to support people to manage and self-advocate in workplace settings. All the research on self-management in workplaces and self-advocacy in workplace shows that people's ability to stay in work is much enhanced if they're taking more control over supporting their boss to help them make accommodations based on a capacity rather than incapacity perspective. So as I said, most of my research focuses on understanding the impact of labour market participation, productivity, inclusion of chronic fluctuating health conditions. And I speak at a lot of these scientific congresses and conferences representing a range of specialties. I was trying to think about the ones I've spoken at in the last 5 years: rheumatology, psychiatry, osteopathy, neurology, gastroenterology. And one of the common factors is that people living with rheumatoid arthritis, schizophrenia, osteoarthritis, MS, inflammatory bowel disease, obesity, want to work for the most part. And we need to do what more through joined-up action in the healthcare system, the welfare system, and employers to coordinate our efforts to make sure people who want to work can do so. Up to 60% of people of working age with a chronic or fluctuating health condition are the primary income earners in their household. So this is not just about wanting to hang on to a job. This is an economic need. And of course, the biggest financial burden of falling out of work doesn't fall on the government, it falls on individuals and their families. And for many, the early retirement option has disappeared. So we need to do more. And my first chart showing how ageing and working longer are going to be big factors driving policy in this area are unavoidable, so we need to do something. I suppose the other common factor I find about these very impressive and eminent scientific congresses and symposia is that I'm often the only speaker addressing the challenges of employment. And I think that's true in this Congress as well. Now, of course, you know, I'm not arguing that everyone should be talking about it, but it's just interesting when you scrutinise the programmes of these events where the priority is, and everyone's really interested in genetics and the clinical aspects of all this, and it's really important that basic science in this area progresses. But if you rank the things that are most important to people living with a chronic or fluctuating health condition like obesity, it's work and employment. Work is not just an economic act, it's a social act. And if we continue to leave obesity discrimination both in the labour market and in modern workplaces unchallenged, then we're contributing to the continuation of a form of social exclusion and disadvantage which can no longer be justified. So let's all work, all of us, to bring about some change. Thank you very much.
Thank you very much, Stephen. I'm an occupational therapist, so I have lots of questions, but it's not my time. So anybody have a question, please step up to the mic.
It's Louise Bauer from the University of Sydney. I'm a paediatrician, so I don't normally talk too much about employment in terms of my patients, although I will talk about capacity and quality of life, so I'm just getting in first. I was wondering if you could comment about how strategies for employers to make workplaces or work approaches more appropriate for people with different levels of obesity, or, you know, if needed. I would imagine that for many people with obesity, there would be little or no modification that would be needed, and it may well be people with more severe obesity, the ones who may need that modification. Is there information that's readily available that could help different employers be able to think about those issues? How could you support, train people, etc.?
Okay, yeah, that's a good question. So I think we need to have a very broad definition of adjustments and accommodations. I mean, it's not just about, you know, changing physical layout and using assistive technology. I mean, that's, you know, and OTs are you know, the people to go and talk to. I'm humbled in the presence of an OT because I think they're fantastic. And actually, I think OTs are institutionally meek. They don't push what they do as strongly as they ought to. They're part of a multidisciplinary team. So OTs know about this stuff. They're fantastic. I remember speaking to someone, I spoke at a UK OT conference, and someone said that a patient had said, look, I've got better and I'm back at work. I did it all by myself. And the OT was sitting in the background thinking, yeah, well, okay, I'm glad you think you've done it all by yourself. It's actually, I facilitated that. So it's a quite subtle thing. And it can be working time. It can be have a bit of understanding that someone might need to turn up at 10 o'clock because they have trouble with transport or anxiety about transport. We have a scheme in the UK called Access to Work, which actually not many employers know about, but it's a scheme where if you're an individual who is living with a health condition or an impairment, you can get support paid for by the government to someone come in to your organisation, talk to your employer about how they can make accommodations for you. It can be transport, it can be working at home, it can be working time, it can be physical or assistive technology. It's what some people would call it the government's best kept secret because almost no one knows about it. It makes a massive difference when it's been evaluated to people's ability to stay in work but also improve their psychological well-being. I think that's a really important part of this. So we need to get, I mean, I would say in general that employers are getting more enlightened about this. People quite often say that small employers are terrible at it and they're all Victorian mill owners and so on, but that's absolutely not true. Small businesses need to be agile and flexible in order to be successful. And for the most part, if you've been with that employer for a while, even if you do have an acquired disability or a health impairment, they're much better at seeing what you can still do and rebuilding the job around you. In countries like Finland, the workability model, I think, is an interesting one, which hasn't been properly embraced in other European countries and probably not worldwide, which is sort of way, it's linked in with the welfare system to an extent, but it's a way of doing a systematic analysis of the demands of a job and the competence or the functional or cognitive capacity of the individual and matching the two together. I've just been a judge at a big European award scheme looking at what employers are doing to make adjustments for older workers who have health problems. And some of the things that employers have been doing is fantastic. And actually, they don't cost a lot of money. They make common sense. People who are in receipt of these adjustments for all sorts of conditions feel very grateful and they give much more back in terms of engagement and performance. Everyone wins. And I think for the most part, that's how employers see this. At the moment, I don't think enough of them regard overweight and obesity as part of the family of conditions or impairments that they need to do something about, which is why the point about do we need more of a legal element to that, just to nudge people along would be really important. Also, Sydney University, Deborah Schofield in the clinical trials unit, say hi. I visited her a couple of years ago. They're doing great work on how chronic conditions affect people's ability to stay in or leave the labour market. It's fantastic work, so say hi to you.
Little social engagement too. Just one quick comment, and I know we have another question. So I love what I'm hearing, and I think, we'll put you as an honorary OT because I think you're probably doing some great stuff. One of the things that comes up time and time again when I'm working with clients is embarrassment or fear of raising the need for, a more supportive work chair or a larger work environment or some chairs or resting spots in the hallways or boardrooms or time to change and those kinds of things. So I think it's really important for those of us who are working with clients who have obesity to either, whatever capacity it might be, is to ask those questions, like you say, make work an outcome. Ask about that engagement because oftentimes people are uncomfortable raising those issues, or I've often heard from people, I don't deserve those accommodations, I don't have a disability, and just reframing that just to increase that engagement would be really helpful. You had a question, I believe. Yes.
Hi, Sven Schubert from the ECO Patient Council. Thanks, Stephen. This is the second time in a week that I'm listening to your talk.
Worried you might get bored.
Well, it must be good. So, well, I'm an obesity patient, and I used to weigh 300 kilos, and somewhere on the way to reaching 300, I had to stop doing my office job because my company wasn't or the anyway, it didn't happen. I didn't get a bigger chair, and I was kind of being hassled for being late, and there was a disciplinary procedure going on. And the idea to actually go to my GP and say, I can't work, it's destroying me, it didn't occur to me. It was my GP who had to tell me, look, I'm signing you off sick because this is not going to help you. And when I came back, everything had changed. You know, everything was being facilitated for, and the attitude had completely changed. And so I've seen both sides, and how one thing can be actually bad for you in terms of working with obesity, and how being facilitated for it is extremely empowering. And on the other hand, and we all wonder, why is work important for people with obesity? Every single aspect of therapy, bar the bariatric surgery, food, exercise, behavior, if you don't have a job, you can't afford any of this. You cannot afford to buy good food. You cannot afford to go exercising. Everything hinges on income to fund your getting better. So I think it's extremely important, and I really want to hear more and more often about this.
Well, I absolutely agree, and that's a really good just a couple of examples that you've given there, because I think that probably echoes a lot of people's lived experience. Now, I would say that there's a sort of critical mass effect, I think, that as more employers, partly because of regulation, have to think about making adjustments for people with conditions they regard as legitimate conditions, such as, I mean, the classic one I always use as an example is if you break your leg or you've been skiing, that's difficult for an employer, but they know that after 8 to 12 weeks, you're going to be back. And there's a sort of linear progression of healing, isn't there? And, no one ever will stigmatise you for having broken your leg. But a condition that is more complex, where people have got strange or, incorrect beliefs about the causes, or blame the individual, and so on, it's much more difficult. So I think, we need gradually to get employers to recognise that making adjustments is not difficult, it's not that expensive. There's some good Canadian work, I think, that shows, I think the Canadian Abilities Foundation did some work that showed that the average cost of a workplace accommodation is less than $200 or something. It's tiny, and it's usually temporary. So as we get more employers to embrace this, the more they'll realise, and particularly if we can encourage people to be self-advocating, and saying, I could still do my job if you allowed me to do this, that sounds really easy to say. It's not easy for people to say. We're tackling stigma in a whole range of areas. Mental health stigma is another one we're really struggling with. But the more progress we make, the better it'll be. And it'll just become normal for employers to think about 3 or 4 things they could do to help someone, and then forget about it, and you get on with it. And I hope we reach that stage very soon. But I think some people say that obesity is the last characteristic that's still socially acceptable to be able to make fun of and to discriminate against. And we're winning that battle gradually, but it's still very slow. But I think we'll get there.
Yeah. Could I just add to that as well? I'm just speaking more. We have a little bit of time. There was a study that you had shown up there, Stephen, that talked about the association of obesity with lost time at work, productivity, disability days, that kind of stuff. And I would really encourage researchers to really be careful how they pitch or how they write about those results, because when we see that, the first instinct that employers have is, if I have employees who have obesity, they're going to be expensive, they're not going to be productive, because it becomes an individual's issue, rather than looking at what factors are in that place of employment that might be creating days off, lateness, presenteeism, absenteeism. Is it's likely the factors in the built-in social environment within the workplace, not necessarily the fact that that person living with obesity isn't capable of doing the job. So for those of you doing research, be really mindful of the way in which your results are interpreted, that you put those little caveats that there's other things we don't know, because the media is great at grabbing those headlines and saying, don't hire obese people. Obese people cost us money, and that's not what this research is saying at all. So right. I thought I was really interested in that, because I think that's the first thing we jump to.
Absolutely. Well, I mean, Dominique talked about the virtuous, the downward spiral, if you like. and I think one of the things that she didn't mention is two concepts. One was self-efficacy. So she talked about self-confidence and self-esteem. Self-efficacy, which is really important, it's linked to agency theory, the concept that you have a belief that you can do something. If that gets eroded through discrimination and stigma, then it just means you can't do stuff. You can't motivate yourself to do it. You don't believe you can do it. That's one thing. And then self-stigma is another thing. And that's actually quite a well-developed concept in the field of mental health, particularly severe and enduring mental illness. And I think it's probably true that there are some people living with obesity who have a self-stigma as well. And of course, if they do that, and if their agency is affected, you end up, despite wanting a good outcome, not to be able to motivate yourself to do things. So from an employment perspective, you're still at risk of having a worse outcome because the discrimination is having, or the perceived discrimination, having an effect on you. And there's quite a lot of research now on perceived discrimination at work as being as important as actual discrimination.
Are there any other questions or comments before we wrap up the session? It is a little earlier. For those of you who may have come in a bit late, our third speaker was not able to be here today. Did you have, yes, go ahead. You can come up if you can. If not, I'll repeat your question.
Hi, Laura Donnelly from the Daily Telegraph. I was interested in the point about obesity as a protected characteristic and that it's kind of the last one to be sort of accepted in that way. Could you just sort of enlarge on why it's important for it to be a protected characteristic, how it could help someone who is obese for it to be designated in that way?
Okay. Well, I think part of the problem is that there's a widespread belief amongst doctors, employers, society at large. In fact, the UK has the worst figures on this, I think, in surveys, who believe that obesity is self-inflicted. It's a choice. It's a lifestyle choice. It's volitional, if you like. And so that makes it quite different from if you have, I don't know, cystic fibrosis or cerebral palsy and so on. No one says it's your fault that you've got those conditions. And it affects the way that employers, in the case of employers that I'm talking about today, the extent to which they're really prepared to make an effort. And they don't believe that making adjustments for people with obesity is as important or deserved or merited as someone with what they regard as a proper disability. So the concept of a protected characteristic doesn't necessarily mean that we're asking for obesity to be regarded as a disability, but if the consequence of your obesity is you have what clinicians call functional impairment, there are aspects of your daily working life, including your job, you find much more difficult, and you have an impairment as a result of it, and you can't do your job properly. You shouldn't be discriminated against because of that. You should be supported. Now, that's something that we've got to fight a battle. There are strong, persistent beliefs. 57% of GPs in the UK think that people who are living with obesity are doing it are obese because they have low self-control, they're lazy, they're not prepared to make an effort, and so on. That's echoed in the British population. In fact, it's weird that there's no difference between what GPs think and what the wider population think. GPs have got 5 years of medical training. They must have skipped the lecture on obesity, I guess.
They're not getting it, that's the problem.
No, well, that's right. Someone, I think at the conference last week that we were at in Brussels, someone said they get 4 hours or something on obesity in their medical training. So I suppose the argument is if we had a baseline of employment protection and reduced functional capacity as a result of obesity being a baseline that you can't discriminate against, that would help change attitudes, and we build on that. I'm not arguing that the only way to get employers to change their mind is to crack the whip and to pass laws and so on, because that just causes them to be resentful and doesn't encourage them to understand the multifactorial nature of obesity. There's so many complex causes, everyone's different, but we need to challenge this notion that everyone living with obesity is in that position because of bad choices they've made. It's a fundamental error. It's the one that David Cameron, when he set up his review in 2015, I think it was, to sanction people with obesity who are on benefits who didn't go to treatment, it failed because it took a very binary view about what obesity was. It was a set of bad behaviours that people need to be punished for. Hopefully we've moved on somewhat since that. then.
Any other comments, questions? Well, I don't know if our first speaker is still here. I don't see her, so I'd like to thank her, and if you see her, let her know that we thanked her. And also thank you, Stephen, for an excellent talk and discussion. Thank you so much, everybody.